Good morning and good afternoon to all of you joining us online for this event today. I welcome each and every one of you to this webinar. My name is Emily Eberly, and I am your technical host today. Thank you for joining us for our Vessel Health webinar series. Here's a big thank you to Teleflex Medical, who is our sponsor for today's program. And now I'd like to introduce you to Rita Larson, who is our moderator today, and who will introduce you to our speaker. Rita, are you ready to get started?
I'm ready. Thank you so much, Emily. It's great to work with you again. Good morning or afternoon, whatever part of the globe you're in. My name is Rita Larson, and I am the Senior Clinical Marketing Manager at Teleflex. Following our presentation, we welcome your questions. This webinar is accredited for 1 contact hour for nurses and respiratory therapists. The title of today's webinar is Risk Reduction Strategies for Acute Hemodialysis Catheters. Speaking on this very important topic is Amy Barden. Amy Barden is both my friend and colleague and holds a title of Senior Clinical Manager at Teleflex Medical. Amy Barden is a vascular access specialist with over 20 years of critical care and device insertion experience. Through this career, Ms. Barden has been on a vascular access team inserting and educating on vascular device insertion, including arterial, central venous, hemodialysis, and IABP catheters. Amy believes that all patients deserve a no blind stick approach when vascular access is required. Today, Amy shares her knowledge and passion with clinicians around the world as an international speaker and by developing vascular access curriculum and overseeing simulation training courses for physicians and non-physician clinicians. Ms. Barden wishes to disclose she is an employee of Teleflex Medical. This activity has been approved for 1 contact hour of CRCE and CNE by the AARC and California Board of Nursing and the Florida Board of Nursing. At the end of this webinar, you can obtain those continuing education credits by logging on to www.saxtesting.com/VH. You must complete the post-test and evaluation form. Upon successful submission, you will be able to print your certificate of completion. Accreditation is through American Association for Respiratory Care. Our provider today is Sax Communication, and they are approved by the California Board of Registered Nursing and the Florida Board of Nursing Provider. This activity is sponsored and supported by Teleflex Medical. And now, I would like to introduce you to my friend and colleague, Amy Barden Spencer, who will be discussing the very important topic, reducing risk in hemodialysis vascular access, a review of best practices. Amy, the stage is yours.
Thank you for that great introduction, Rita, and welcome to all the participants from around the world. Again, the lecture and the content that I'm going to be covering is really the risk reduction that we have available to us specific to hemodialysis, vascular access, and that patient population. So, just to review the learning objectives for today's webinar, to review the current guidelines associated with placement and use of acute hemodialysis catheters, discuss the vessel health and preservation considerations that each one of us as inserters needs to consider prior to and through the patient's lifespan of catheter placement, discuss risk reduction strategies specific to acute dialysis catheters, but understanding what exactly an acute dialysis catheter is in comparison to other acute catheters in which we already are placing, and to also review the central line associated bloodstream infection reporting compliance and how we're now seeing these acute hemodialysis catheters being reported and what we need to be doing in the clinical practice to try to reduce infection risks in relation. So really the current state of hemodialysis use, and I have to go back in time. So back in 1997, when the KDOQI Guidelines first were initiated, they identified a large group of patients who required hemodialysis access for initial treatment. And they did come up with some great guidelines in which we as clinicians can use and utilize within our facilities. So this is my first question to you as an audience. Do you reference the KDOQI guidelines in regards to hemodialysis patients? And do you reference the KDOQI guidelines in reference when you're placing other vascular access devices that might impair the ability moving forward? So now let's come about 10 years forward in 2006. The KDOQI Association identified 380,000 individuals within the United States that rely heavily on hemodialysis, and this is 10 or 12 years beyond the implementation of the initial guidelines. Now, 10 years later, in a recent publication by Dr. Brame, central venous catheters are used to provide acute hemodialysis in a majority of patients who are initiating dialysis or awaiting maturation of existing access. So again, I want you to think about your patient population today in the hospital, and some of you may be joining from the hospital today, so welcome. Think about your acute hemodialysis patients. Are you using that device as a bridge? Is that your most sickest patient population? Do they have a current device that is not matured yet? Or do they have a device that potentially is in place that might be occluded, but they still need that hemodialysis therapy? And what I need to stress to each of you as clinicians is that 82.6% of all vascular access hemodialysis starts with a temporary catheter. So as we move forward, really why are we here? And we're here because now we know that 82.6% is a very large patient population, and this image here is where we probably see them the most. This is where we as clinicians have the most impact and the most potential to change an outcome related to a hemodialysis catheter. Remember, this is just the first stage. If a patient requires acute hemodialysis, they're in one of two phases. They're in a phase in which we're going to run them a few times, we're going to place a catheter, we're going to clear their lab values, we're going to bring them back into normal and potentially get them out of that acute phase. Other patients, though, tend to have several types of hemodialysis catheters. So we may go from an acute catheter to a tunnel-type catheter. And by definition, it is important to understand that a tunneled catheter is still considered a temporary catheter. So again, think about your hospital and how many times you're seeing this type of attrition moving from one acute type catheter to a second tunnel type catheter. And why this is important to you as a vascular access clinician is depending on your insertion area, depending on the catheter, depending on the patency of the catheter, and depending on the aseptic use of that first catheter in which you placed, will determine whether that tunneled catheter can go within the same area if the patient has to have another type of device, if it has to be moved to a separate location. So very, very important considerations when you are looking at insertion and then also care and maintenance. The next image really is, remember, these patients have a large lifespan. When we think about acute dialysis, it's just the beginning of their therapy in a lot of this patient population. So is this patient now waiting for a graft to mature? Are they waiting, are they moving from a tunnel type device now to a graft type of device? And the last option is a fistula. So again, as a vascular access specialist or an initial inserter of an acute hemodialysis catheter, we want to understand what the patient has, what they have had, what the true options are, and what the future of their access is going to be so that we can protect them from the beginning and we can utilize the space in which will not compromise space in the future for them. And really, this is our world. If I was in any of the facilities with you today and watching this webinar, if you had a minute, this is what we work with today. Patients are no longer just on one pump or two pumps. We have a multi patient demographic that are very, very sick that we treat for a long period of time. And acute dialysis catheters are used for several functions with a lot of manipulation by the healthcare provider within those institutions. And I have to stress to you that when you think about device insertion and you perform that procedure, that is 1% of the life of the catheter. So we do all of the protection processes that we can do, but really it is the care and maintenance bundle, and we're going to review that as we go through the slide deck today. So let's talk about the National Kidney Foundation and the KDOQI Guidelines. As I said earlier, they were published originally in 1997, and they were updated in 2006. And today, we still have no new evidence or publications from that association, but we have a lot of evidence from other associations in which I'm going to share with you throughout this presentation. What's very important is that as vascular access specialists or people who have that are taking care or maintaining central venous access devices, it's very important that we read and are up on the latest evidence. And I'm going to show you some historical evidence through this presentation. But each of these points in which I'm going to touch on, you can pull the latest and greatest evidence that's being published almost every day. So this is the current foundation for vascular access and hemodialysis, therapies. And hemodialysis really reaches that broad spectrum from acute catheters to long-term catheters through the tunneled phase, but also to the fistulas and the grafts formations for patients. And failure of access was noted in the majority, a major cause of mortality in patients with hemodialysis therapy, and that's really why the KDOQI Foundation came up with these guidelines in 2006. And we have patients in several stages of chronic kidney dysfunction, and it's really important that we as vascular access specialists, whoever is maintaining these devices, understands what phase our patient's in and how we can best initiate therapy, but also think about the prolonged therapy requirement. So really the use of temporary access from a National Kidney Foundation perspective states that only 10% of hemodialysis patients should be dialyzed with this type of acute catheter or a tunneled catheter. Clinicians and patients should advocate fistula first. So again, I'm going to ask you in your own facility, in your own hospital policy and procedure today, do you reference the KDOQI guidelines? Do you have an integrated relationship with your nephrology group that when you identify a patient that you've been asked to place a device in, is there a fistula first thought process? Is there a tool that you use in your facility to identify whether that patient really should hold off on that type of catheter and really move to a fistula first? This is something we really need to consider in the United States, especially with our patient population that's currently requiring acute hemodialysis, because remember, they're going to move down that pathway to several other potential devices. And temporary and tunneled catheters do remain popular, and Dr. Bream identified this again in his publication just this year, that we do place a lot of temporary catheters for hemodialysis. Therefore, all the protective strategies in which we have today that have been evidenced should be put forward and utilized to reduce risk to these patients. Remember that 82.6%, which is a lot of our patient population, initiates hemodialysis with an acute catheter. Therefore, we have the ability in our own practice, in our hospitals today, to impact 82.6% of patient outcomes just by the device in which we choose, by the place in which we place it, by the insertion technique that we use, and by the care and maintenance bundle in which we implement after the insertion. So today we're really going to focus on the first stage. And the first stage really is acute hemodialysis placement. So in today's world of vascular access, We have specialized teams throughout the United States and in several other countries that have been identified to do repeat procedures. A small team focusing on best practices. These teams can include nursing, they can include respiratory therapy, they can include radiology, they can include physicians and nursing, they include physician assistants, nurse practitioners, who, regardless of who they are within their own institution. And you may be saying, Amy, you missed somebody. In your own institution, it is most important that you identify the group that takes care of this patient population. Because remember, an acute hemodialysis catheter is a central venous catheter. And a central venous catheter is a central venous access device. So if we keep that thought process throughout this presentation, you'll understand through the evidence of acute CVC placement, rolling into acute hemodialysis catheter placement, and understanding the care and maintenance related to all CVADs in which we place in our hospitals today. The care and maintenance and the catheter dwell have a huge risk reduction opportunity as long as we educate and we device select appropriately. So why is it important? The guidelines and structure that were put in well beyond the KDOQI guidelines helped us as clinicians to reduce central line associated bloodstream infection between 2008 and 2013 by 46%. So you might be saying to yourself, why did that happen, or how did that happen? And it happened because this is when the CDC guidelines were conformed, when bundle compliance strategies were put into place, when checklists started to come into practice where we were required to use a checklist for insertion and make sure we were doing the right thing at the bedside. And 46% reduction in central line associated bloodstream infection by doing those simple pre-procedure and procedural tasks had a huge impact on patients requiring hospitalization and also requiring catheters for a long period of time. So we know that 31,000 central line associated bloodstream infections happen annually in hospitals in the U.S. today. And we also understand that there are lots of tools and procedures and competency and education now that's being reinforced to make sure that we're compliant and that we're doing procedural compliance with every type of device that we do. So again, I'm going to go back to a CVC. If you think about in your practice today, when you go to place a CVC at the bedside, you have a cart, you have a kit, you have an assistant, you have an ultrasound because it's required. When you go to place an acute hemodialysis catheter, it's the same. You have a cart, you have a kit, you have an assistant, you have a catheter, you have a checklist. All of that is exactly the same. As a matter of fact, the inserter should be the same. When you're talking acute hemodialysis, those teams that are placing those CVCs on a daily basis should also be those ones that are placing those acute hemodialysis patients to preserve that best practice opportunity and to maintain the same team doing the same processes. Regardless of whether the catheter is used for something different in therapy, it should be the same team in which is placing those devices. So Dr. Bream continued to say in his article in 2016 that there are benefits to using acute HD or CVC type catheters for acute hemodialysis. And one of the highlights is, in which we know from a CVC perspective, that there's this variety of sites for placement. That there are several different options when we think about scanning a patient with an ultrasound and having to identify the best place for insertion. From an acute dialysis point of view, the right IJ is the most optimal site for placement for a hemodialysis catheter. It's a direct insertion technique. There's no tortuous pathway. But remember, not every patient comes with a perfect anatomy, and not every patient comes free of other catheters in that same position. He also highlighted that they are immediately available for use. Different than those later stage patients' requirements such as fistulas and grafts, or even potentially having a tunneled catheter placed in interventional radiology, there is a delay in care. So when you ask yourself why 82.6% of all patients start with hemodialysis with an acute catheter, it's because they can use it right away. Insertion is performed at the bedside with use of ultrasound, an X-ray confirms tip location, and the patient is cleared to be used for dialysis for the catheter. That is just a very easy and natural process. And think about the process in your hospital today. If you do not have a team that places hemodialysis catheters, think of the team that does, and think of how much time it requires for your patient to either be transported or for the catheter to be placed, and how long it takes for that catheter to be used for the first time once it is placed. It's always interesting because every facility is just a little bit different. These catheters are relatively low cost and easy to place and to replace. So again, the kit formation, the catheter body type, the ease of placement, being at bedside, not having to transport a patient or having a specialty discipline come in makes the insertion relatively low cost and also low risk. Venipuncture is not required for dialysis, so this gets into the patient. You know, when you give patients options, and every patient should have an option, when you give a patient an option as to getting stuck through a graft or a fistula for dialysis runs, or just having the lumens external to the body, if it's up to the patient and it's not for a long period of time, and you have to question whether they needed the fistula or graft at that point, they may just decide that they don't want, you know, that needle stick through the skin. So that's a huge conversation that we have to have from the beginning, and make sure that we understand what we think the lifespan of that kidney disease is going to be. And the last one is thrombotic complications are relatively straightforward to correct, meaning if you have a catheter, it becomes occluded, that we cannot declot or get fixed, or so reperfused, basically. Those catheters either are exchanged in some institutions, or they'll send the patient to interventional radiology, and they'll do multiple procedures in interventional radiology to get rid of that occlusion within those catheters. Different than if the patient has a shunt or graft that fails either from vessel collapse or the maturation didn't occur. Those are longer and more extensive problems that occur. From a disadvantage point of view, they do have drawbacks. Every catheter has drawbacks. But this one, it has the highest morbidity of all access devices due to thrombosis and infection. And I think, you know, if I had to say a call to action, I think as a vascular access specialist around the world, and I mean, when I say vascular access specialist, I really mean you. Anybody on this call, anybody who took an hour out of their day to learn about hemodialysis catheter, you're taking that first step to make sure that you're doing the best for the patient. So if you think about the highest mortality and morbidity, these catheters are highly manipulated. They're also packed when they're not in use. They're taped off potentially. So again, think about the last patient that you saw with an acute hemodialysis catheter. What did the lumens look like? Were they fresh and clean? Did they have tape around them that said packed and do not use? Was it up back in the patient's hair? Where was the catheter and how was it sitting? Because remember, with the patients with highest mortality, they do have a high morbidity because of the demographic and their medical disorders. But there are things that we as clinicians can definitely stop to improve the patient outcome related to hemodialysis catheters. And hopefully this statement goes away over time. The next one, it really does cause central venous stenosis and occlusion. And that is why the KDOQI guidelines stress that we do not place acute hemodialysis catheter or any large bore type of catheter into the subclavian vein. We do not want to place that because remember, large bore potential, it potentiates occlusion and stricture and thrombosis in that subclavian vein. Therefore, we do use and recommend the IJ for insertion as our first site of choice for hemodialysis catheters. And remember the right side, because the left side has a much more tortuous pathway. The external hubs are disfiguring and cause a lack of patient satisfaction. Remember, patients go home with different types of devices, and they don't want their medical history outside their clothes. They don't want their friends to know what's going on in their life potentially. Their family, their family is probably a big part of care and maintenance, and they want to make sure that the lumens, the hubs, nothing adds a medical history component to them, which they don't want to share with the outside world. And the last one is that the relatively low blood flow demands longer dialysis times. So again, I want you to go back to your hospital, think about your storeroom, and think about the different catheters you have available for hemodialysis. When you pick and choose the different types of dialysis catheters in which you have and we use in our patients, it's very important that we consider the flow rate. And remember that hemodialysis is not being used just for an acute run of hemodialysis. It's also being used for continuous renal replacement therapy, which is done on patients who do not have a sustainable blood pressure, that they have a continuous run of dialysis within the ICU units. And we're seeing a lot more of that demographically throughout the U.S. and throughout the rest of the world. So always consider what the flow rate of the catheter has, and make sure that when you're looking at different types of catheters and you go back and you troubleshoot, look at flush regimens, look at packing, who's caring for the device. All of those will impact the flow rate besides just the body habitus of the catheter itself. So we do have lots of guidelines. And as specialists, we should be up on everything. And I say that with a little bit of chuckle because there are so many articles and great publications coming out. But I always revert back to the guidelines and I find the latest evidence to support. So for example, the CDC came out in 2011. I'm hoping to get an update from them soon. But the INS guidelines just came out. So those are fresh and new. The KDOQI Guidelines, we haven't had an update since 2006. But the SHEA guidelines, the most recent publication, central venous catheter related, was just published in 2014, and I'm going to review some of those guidelines in specifics. So this is the CDC evidence that came out. Remember, this comes out in 2001, again in 8 and 9, and then again in 2011, looking at central line-associated bloodstream infection risk in the United States, showing how many lives potential that we could save by putting in practice bundle strategies, using antiseptic technology, and really upskilling the clinician at the bedside and making an awareness of where patients are within the hospital and what the risks of infections are. Just almost broadening an awareness to the clinical community that saving lives matters, and we have a potential to save a lot of lives just by putting simple structure into place. So this was the very first evidence that started to come out in 2001, and then we moved to the CDC guidelines that came out in 2011. Now personally, I carry these around with me. If not, I have the app on my phone, so I encourage all of you to have it. Every policy and procedure in the hospital in which we practice by should have reference to the CDC guidelines and then the most current evidence beyond the CDC guidelines. But some of the things that stood out to me and that I advocate for, and really from a hemodialysis catheter potential, we need to keep in mind. So education and training of the healthcare professional who inserts and maintains catheters. We hear this a lot with central venous catheters, but remember, a central venous catheter and an acute hemodialysis catheter are the exact same type of catheter. So who in your facility is doing insertion, who's doing care and maintenance, and how is that training performed on hire and annually? Using maximal sterile barrier precautions during central line insertion. This is no longer an option. This is something that is definitely required and should be identified on your CLIP guideline during catheter insertion. This is a minimal requirement for central venous catheter insertion anywhere that you would travel around the world. The use of chlorhexidine in skin prep is one of the biggest risk reduction opportunities that we as healthcare clinicians have seen. The evidence states that a greater than 0.5% chlorhexidine and 70% alcohol should be used as a skin prep on cleaned skin. You prep with your chlorhexidine, and then several strategies also are utilizing chlorhexidine skin bathing, and we'll talk about that a little later in the presentation. The last one really is to avoid replacement of CVADs as a strategy to prevent infection. We should not be replacing same types of catheters within the same body habitus area, as we know that bacteremia is already within the system. If it's extraluminal, it may be within the same intima structure that we're going to exchange a catheter to. The CDC guideline in 2011 said we no longer replace any type of central venous catheter if we think that there is an infection at that area. So the next one really is using antiseptic or antibiotic impregnated short-term CVADs and chlorhexidine impregnated style dressings. This is a huge strategy that's happening around the world. And from an antiseptic antibiotic impregnated short-term CVAD, this has been now demonstrated in every guideline that has been recently published that anybody that has a catheter in for greater than 5 days should be considered to have a protected mechanism. So that holds true in your acute hemodialysis patient population, in your central venous catheter patient population, and is strongly moving in your PIC population, so your peripherally inserted central catheters. Performance improvement by implementing bundled strategies. These don't just need to be implemented, but they have to be benchmarked. Quality within your hospital should actually watch the bundle happen. There should be guidelines for documentation. And if the bundle for some reason is not maintained, how does your team deal with that situation? It's so very important. I'm going to just go back to the antiseptic, antibiotic impregnated short-term CVAD. Think in your hospital. I'm giving you lots of homework through this presentation. So think in your hospital. Why is your catheter a certain color? What kind of catheter do I use? And remember that if you work in anesthesia in the OR, for example, you almost have to predict the life of the catheter, because the guideline states today, if the patient is going to have an acute type catheter for greater than 5 days, that they should be protected. And remember that when we protect patients, what are we protecting them from? We're protecting them from their own body habitus, and we're protecting them from us as clinicians, because these devices are highly manipulated and they go to several areas in the hospital. And then we move to SHEA. So SHEA did their update in July of 2014, specifically about reducing risk of bloodstream infection in acute care hospitals. It is a great document, and if you have not had a chance to read this document, please download it after this presentation. It really does focus on the key elements and structure in which we need to provide the best evidence-based care. And from a level of evidence standard, I want to show you specifically several identified infrastructures that SHEA has put into place that are a level 1 evidence that has the highest confidence that true effect lies close to that or of the estimated size and direction of the effect. This is the highest level of evidence that we can have in clinical practice, and at minimal, we should be instituting these recommendations. So from a SHEA recommendation, some of the best practices identified just from a catheter insertion bundle strategy. And let's look at the level 1 first. Insertion site, to avoid the femoral site. We know that, and we take precautions when we have to use the femoral site, but we also need to identify why we used it in our documentation in case that's the only site that's left. Max barrier precautions for all line insertion, level 1. Chlorhexidine skin prep, level 1. Scrub the hub. Remember that once we walk away from the patient, a lot of those late onset bloodstream infections happen from care and maintenance and happen from hub manipulation. So scrub the hub. Have your team demonstrate how they do that to you. We talk about scrubbing, we talk about squeezing an orange. Some people chuckle about that, but that makes a big impact on the patient outcome. Some of the level 2 items under best practice include the catheter checklist. They also include the cart and using a specialized kit Because what happens is when we come in and out of a room, or we're forced to come in and out of a room to gather equipment, what happens to our compliance with the procedure? If we're waiting for somebody and we know it's going to be 10 or 15 minutes during a procedure, what's the likelihood that we're going to follow all the steps if we don't have the tools necessary? A level 2 also included hand hygiene. There are several moments of hygiene with your hands that need to be addressed. Some hospitals have moved to that 4-minute scrub in the morning, and they use that gel for the rest of the day. Some hospitals have gone to gel all day for every procedure. What's most important is that you audit what you do and that you know what you do and know what your hand hygiene rate is in your hospital. That would be a best practice. So the next one really is special approaches from a catheter maintenance relation. Remember, insertion is only 1% of the life of the catheter and 99% is the dwell. So chlorhexidine bathing is a level 1. Impregnated catheters is a level 1. CHG impregnated discs, some kind of antimicrobial at the exit site. And then an antimicrobial lock, depending on your patient population and what other comorbidities that they have going on. And I have to bring you back around to the impregnated catheter. We use it in your CVC every day. Silver sulfadiazide and chlorhexidine impregnated catheters. You may have an antibiotic type catheter, and you may have a metallic type of protective catheter. If your catheter is going to dwell for greater than 5 days, it is the recommendation by the SHEA of 2014 that it is an impregnated catheter. So homework again, go back and look to see what you're using within your facility, because if you're trying to reduce your central line associated bloodstream infection rates, that matters. Catheters matter. So the known factors that influence CLABSI, we know a lot of these. The patient, the demographic of the patient, what's going on with them, the type, the number, and the site of insertion. We know that the CDC recommends subclavian as the first site of choice due to risk reduction in infection, but we also know that the IJ is the best vessel for an acute hemodialysis catheter. The types of connectors that we use, whether it's with the needleless connectors today, there's split septums, there's mechanical valves, but remember, we also add stopcocks. So depending on what your hospital practice is, the evidence says remove everything that you can out of the system. Don't have stopcocks. Don't have add-on devices if you don't need them. But you do have to have a needleless connector that works well, that functions with your catheter, and that all of the healthcare clinicians in your hospital understand how to use. What infusions? What medications are we actually infusing, and do they potentiate increased risk? Who inserts, manipulates the catheter? And this is where I say, do you have a vascular access team or not? Statistically, as I travel around, the patient care and the outcome metrics, when I compare an academic center where everybody has to place devices because it's an academic center and that's part of the academic curriculum, or when I go to a smaller hospital where they have a vascular access team that includes multiple different disciplines, as I mentioned before, that care for devices on insertion all the way through removal, you see the different patient outcomes and staff satisfaction, but also patient satisfaction. The method of documenting your BSIs, we have to be strict and structured on how we document BSIs and not manipulate the number because we don't want one. But what we really need to do is to make sure that we have all of the evidence current and we have everything put into place so that we can reduce risk. And actually, if we have a positive BSI, it's okay. What do we do with that? We troubleshoot. We figure out what was the gap, who was on the team, how can we fix it. We don't cover it up by calling it something else. Interpretation and application of the CDC or other CLABSI definition protocols. This is very important. Use the latest evidence. And the last one really is involve infection control. Hand hygiene audits and procedural-based audits should be performed every day throughout your units in which catheters are being placed. Then there's other risk factors, such as the independent ones for central line associated bloodstream infection, and these were identified in several publications and most recently in SHEA. And I've highlighted a few of them that are very, very important. So heavy microbial colonization at the insertion site. And how do we as inserters fix that? We clean the skin. We prep the skin. We avoid the folded areas. We avoid the penice that may lay over a femoral type catheter if we're forced to go into the groin. We use ultrasound and get rid of the high bioburden, get out of that high bioburden zone. And the next one is heavy microbial colonization at the catheter hub. What do we do for that? We do scrubbing the hub, lots of education, routine catheter hub changes. Make sure that that is always done very, very effectively. And minimize the touches on the actual lumens themselves. High IJ catheters. We really want to go low, and I'll talk about that as we get into the anatomy. Femoral catheterization in adults, try to avoid that. And then the last one really is hemodialysis. That patient population alone has a high risk. So we should know and understand that. So 5 evidence-based approaches that have been put into place, and we know this because they first came out in 2006, and then in 2008, again in 2011. So hand hygiene, max barrier precautions, use of chlorhexidine, and this is just really reiterating some of the practices that I've already gone over with you. Avoiding the groin, and the last one is that daily surveillance, making sure that we survey every day why that catheter is in, and if it's not a team that does your catheter maintenance and care, who and how are they identifying when that catheter can come out? So let's start with the first one, hand hygiene. Hand hygiene, there's 5 moments of hand hygiene, and I'm sure that you all know what they are. Before you touch the patient, before you do the procedure, after a procedure or body fluid exposure, after touching the patient, and after touching patient surroundings. So there's several moments in which you should be washing your hands to be compliant with the 5 moments of hand hygiene. And on national average, most hospitals in most countries are on average about 70%. And then this is the bacterial root of all evil. You do see this slide probably in several different genres and over the years, but it's very impactful to me. Healthcare clinicians' hands, when the average hand hygiene rate is about 70% internationally, and the compliance with gloves and use of gloves, it does impact the colonization ability for catheter hub junctures. Catheter hub colonization, we know that spikes over several days, and those caps need to be routinely changed and documented that that's been done. The skin on the body, the normal flora of the patient's skin, that's why we use chlorhexidine, and we prep the skin vigorously and we allow it to fully dry. And then the hemogenous spread, the natural normal seeding that occurs in infected patients. So we have to understand that each one of these matters. But what I want to point out to you on this slide is that on the extraluminal portion of the catheter, anywhere from 40 to 70% of infections are related to the extraluminal portion of the catheter. And interluminally, anywhere from 20 to about 40% is where that occurs. And this is specific to hemodialysis catheters. I just want to point this out to you, that looking at hemodialysis catheters, and this was a study that was done by Mackey a long time ago, non-cuffed catheters have about a 16.2 per 100 catheters, with cuffed catheters being a 6.3. And remember why the cuff came into play, to make sure that the catheter stayed in situ, but also to reduce any microorganism from coming up into, from the catheter exit site into the bloodstream. But then look up at short-term catheters, because remember what an acute dialysis catheter is. It is an acute CVC, if you can think of it in that same mindset. It's a 3.3 per 1,000 catheter days, or a 3.3 per 100 catheters, or 2.3 per 100 catheter days, or 1,000 catheter days. And that is really important when you think about reducing risk and how we're correlating acute catheters to long-term catheters, or acute hemodialysis catheters to central venous catheters. So some of the trends that are happening right now in hemodialysis, and this is looking really at mortality and morbidity, and this is the evidence that show that 82.6% of all hemodialysis is started with an acute dialysis catheter. There was a lot less mortality and morbidity associated when the patient could wait for an AV fistula or graft. but it really resonates back to the clinical world that we're not waiting for those catheters to be placed and that we are placing more acute dialysis catheters and some of the structures that we need to put in place to reinforce best practice. So this really looks at max barrier precautions, and on one side of the screen is what how we should be donned and draped and gowned, so gloves correct and gloves not correct, mask correct, hat not correct, and really looking to make sure we have best practice, and only you can do this through auditing your own process in your hospital. And then we're going to look at some not max barrier precautions. Although we're using ultrasound, the image on the screen is not max barrier precautions. You see that the patient is not fully draped, the hands are not protected, and then the second image is they're using ultrasound, great, the patient is draped, but you also have assistants in there that don't have their headdress on and their masks in place. So very important that the entire team follows the max barrier precautions. So when you think of the 3 studies, there was 3 done, Mermel in 91, Rod in 1994, and then Lee in 2008, really looking at why and when we should do max barrier precautions. And this is that underpinning evidence to continue the CDC guideline and the SHEA compendium to make sure that we're doing full max barrier and that everybody in the room is protected and protecting the patient. And then looking specifically at chlorhexidine and alcohol as a skin prep, we have known this for a very long time that chlorhexidine as a skin prep supersedes the use of iodine or betadine, and that the application is very different. And this single meta-analysis showed that CHG reduces the risk of CLABSI by 49%. So just this one body of evidence that looked through several different articles of reference, several meta-analysis with a high risk ratio, looked to see that chlorhexidine did perform superior, and that is what we should be using, and this has been established guideline for a long time. So then we looked at the most recent article from SAFDAR on use of chlorhexidine at the exit site. And what we have to relate here is, remember, the use of chlorhexidine from a skin prep to prepping the skin for insertion to dressing the catheter once the catheter is in place. The most common route of infection occurs at the insertion where skin organisms invade the percutaneous tract. That is very, very important because if you look all the way over on your slide, your catheter is very important here. So when you think about protecting the patient with a catheter that has chlorhexidine and silver sulfadiazide on it, you're really protecting the patient beyond the insertion. So in this reference alone from an external protective mechanism, 40% patients had a decrease in risk in CRBSI, 48% decrease in colonization. In all of the study participants in this group, subclavian IJ sites were used, and also the dwell times were very similar. So if you have not read this article, this is one that's really, really a great read for you. And then when you think about site selection, IJ, and we talked about earlier, the IJ is very, very important, but also low approach IJ, because you have to take into account the length of your catheter and your insertion point. So the higher the catheter is placed towards the ear, the less likely your tip is going to terminate at the SVC or cavo-atrial junction. We really want that tip lower for better blood dilution and less risk of thrombosis. That has been highly evidenced. So very important that we try to get very low on the IJ and not to have the catheter up towards the patient's face or ear for both maintenance and for tip location. So these are just a few other considerations when you think about site selection, anatomical deformity, presence of coagulopathy. We have to consider each of these when we're choosing the best site in which we place our hemodialysis catheter. So the use of ultrasound has been highly evidenced, and this is for your reference, really. It started in 2002, several different associations. The CDC was one of those, again, brought that back out in the 2011 guidelines. The EPIC 3 and then SHEA, the last one in 2014, really considers that we should not be placing blind catheters. We want an anatomical approach, yes, but we want to be able to see that anatomy with ultrasound to make sure that we're placing the device in the most appropriate patent vessel available for the patient's developed therapy. And then Bream, so let's bring it back to the 2016 article that we've been referencing through this presentation. So he looked specifically at complications related to central venous catheters for hemodialysis. And I think that one of the biggest things that he pointed out in his article, in his conclusion, was that they are used highly by different clinicians throughout the hospital. And also a lot of patients, that 82.6% patients still get a acute hemodialysis catheter for treatment. And the only way that we can protect the patients that are receiving those types of catheters is that each clinician understands the complications and adheres to the guidelines that protects the patients and put the patient first. So tip positioning, I know that you're all wondering, has that changed for a temporary dialysis catheter? No, it still is. The short-term temporary catheters are still in the superior vena cava, and the longer-term catheters, they really place in the right atrium. This goes back to the KDOQI Guidelines, CPG 2.4. This is the basic principles for tip location from a hemodialysis catheter point of view. So other special considerations, and I've already sort of gone through most of these. So the use of antiseptic catheters, chlorhexidine impregnated dressings, that's just reiteration. Making sure that the scrubbing the hub and the cap is done by everybody within the organization, and that the antimicrobial catheters, again, are that protection beyond the insertion. So when we walk away from the patient, what are the multi-factors of who's going to care for the device? How is the care going to be performed? Is the patient going to stay in the hospital? And think about the long-term impact of the maintenance, because remember, again, the maintenance is 99% of the patient of the dwell of the catheter. And I have to have you think, using that protective mechanism as the SHEA guideline recommends, chlorhexidine and silver sulfate diazide impregnated catheters with that extra luminal protection to reduce the risk to the patients who have a long dwell for acute hemodialysis catheter. 82.6% of patients receive this type of device throughout the world, and on a daily basis there are several patients within each hospital receiving this by a multi-array of people, different clinicians with potentially different insertion practices. So we should have a dedicated cart for use within our hospitals today. This was evidenced many years ago, and several hospitals are continuing to become compliant with this from an efficiency point of view, but also a standardization. And the cart should be mobile so that you have a cart that walks through the hospital with you and that has everything on it that you need as a clinician to place the device effectively, efficiently, but also has options and choice for the patient. And the message really is to standardize. Standardize what you're doing in your hospital to make sure that the patient has the biggest impact in the end. So post-insertion care, there is some differences between CVCs and acute hemodialysis catheters, and one of them is the antimicrobial ointments. They do use an ointment at a hemodialysis catheter exit site where they no longer do that for CVC, so that's a little bit different, should be different in your policy. The sterile dressing at the exit site, very, very important. Semi-permeable transparent dressing should be done where you should visibly see the site. These are larger bore catheters, so make sure that we're monitoring post-insertion bleeding and that we are placing a protective barrier once that bleeding has resolved, because that allows that dressing to then be extended for a longer period of time. So here's the one of the last articles that I'll show you, and this is the chlorhexidine impregnated, or the bathing of the chlorhexidine washes. So any patient that has a catheter in place in the hospital, A strategy to reduce central line-associated bloodstream infection really has been to employ a once a day or an interval determined by your institution, dichlorhexidine bathing to reduce risk of CLABSI. They bathe the extremity plus the body, and some hospitals have also started bathing the tubing, so they actually clean the tubing. You do need to use a needleless connector, as I stated before, for all of the hubs and or stopcocks. It does have to have an ease of use ability to it. You do want to minimize stopcocks and educate and maintain that closed system. That education is crucial. There are 70 different needleless access devices on the market, and each one of them will impact your catheter differently. Very important that anytime you bring a new type of device in that is used on a catheter, that everybody's educated. Asepsis to the needle connector, scrub the hub. I went through that, but I'll keep this slide in here because you'll be able to download these slides. Based on the new evidence, it's a 5 to 60 second scrub, and that's based on the manufacturer's recommendations for use with each of those. So make sure that you pay special attention to that aspect of it. Every hospital seems to be doing something a little bit different, and we need to standardize there. The last thing I'll talk briefly about is locking. So locking hemodialysis central venous access devices with heparin is a standard of practice. 1,000 units per ml is the standard. Those get locked, packed and locked, and usually some kind of identifier so that the clinician isn't using them. Hemodialysis catheters are not normally used for anything else but hemodialysis. And then there's other locking solutions that you can do on a once-a-week strategy basis to reduce CRBSI if you have a patient population in which requires that kind of strategy. And the more catheters normally and the more infections the patient has, the more that strategy is employed in different institutions. Each hospital will have a varying policy and procedure on that. So I guess in the end it really is follow the guidelines, know exactly who your team is, what they're inserting, what your patient demographics is. Understand that CVC and acute hemodialysis catheters are the exact same catheter, requiring the exact same protection to your patient, surveillance and monitoring. All of these are a central venous access device and should have policies and procedures to support your practice. If you have patients have catheters in for greater than 5 days, always consider the protective option. So in summary, we do have and we do know that almost 83% of all acute hemodialysis patients receive treatment via this type of catheter. We do want to do a low approach insertion in that right IJ for most optimal catheter performance and risk reduction. The inserter needs to must comply to reduce risk. So if the inserter, that's the biggest opportunity from an insertion to compile that together. CHD technology significantly reduces risk, and then both insertion and maintenance bundle strategies really need to be applied. Not one is going to help more than the other. We need to put both of them and marry them together, and each hospital should have that solution. So now I am going to turn this back over to Rita.
Thank you, Amy. That was wonderful. You shared a lot of great and valuable information. Just a reminder to all of you that you must register at saxtesting.com/VH to get your credits. So once again, the activity's been approved, and register to get those credits. You must complete the post-test and evaluation form. And so, Amy, we do have many questions. I'll try to get to many of them. So this is from Luke. Why aren't all hemodialysis catheters cuffed and tunneled?
That is a great question, Luke. So not all hemodialysis catheters are cuffed and tunneled because, for one, insertion technique and option. So from an acute standpoint, ease of insertion, the technology that has moved forward. But think about this. The one thing that stands out to me about having every one of them cuffed and tunneled. That means that every single patient, that 82.6% of patients that receive acute hemodialysis, a very large portion of those patients would have to be scheduled at interventional radiology or in a suite in surgery. They would have an automatic delay in care. And I think that Dr. Bream really showed that in his 2016 publication, where it's an immediate use, an immediate availability, and there's no delay. And I know in my own practice, we were able to reduce cycle time from a patient who needed acute hemodialysis coming into the emergency room, getting that catheter placed and getting that patient on a machine rather quickly, where if we only had that one option to tunnel and cuff everything, that might be a huge delay. From an infection point of view, I understand your point. In the world of catheters, if we all go one way, we reduce options and variability. We might even control infection a little bit better. But in today's world, we don't have, it's not a one-only kind of opportunity. And I think it's the patient. We should think about the patient first and the time delay. So that would probably be one of my biggest reasonings.
Okay, thank you, Amy. From Arthella, why are hemodialysis catheter tips placed in the right atrium and not PICCs in other CVCs? It would seem that the firmness of the catheter would damage the right atrium.
That is also a great question. So the long-term catheters, long-term cuffed catheters, are actually the ones that are placed in the right atrium. And that's specific to the KDOQI guidelines in interventional radiology. And they actually like it because it's in a more fluidic and dynamic. There's a lot more blood flow. They have a lot less catheter occlusion, the catheter sitting against the wall. With our standard acute catheters in our own practice, we do cavo-atrial junction or lower third of the superior vena cava. Remember, most catheters have an atraumatic tip on them, and the atraumatic tip is that soft, rounded tip so that we do not have occurrence, negative problems when we're deep into the cardiac region. From a long-term hemodialysis patient use, the catheters that are deeper, that dwell deeper, last longer. And I think, you know, to your point of why our PICCs aren't there, why our central lines aren't there, I think we're getting pretty close when we're at cavo-atrial junction. And I think we're moving in that direction from a performance standpoint.
Thanks, Amy. From David, he's talking about infection. Does Arrow make a Chloragard hemodialysis catheter like the Jack and Chloragard PICC?
So, great question, David. So right now, the protected strategy for acute hemodialysis catheters is the chlorhexidine and silver sulfadiazide AGB, which is generation 1. It's the external protection. But in the future, I foresee something very similar to Chloragard being needed on acute hemodialysis catheters, because we know that they have the highest mortality and morbidity due to just their body habitus and infection opportunities. So I see that coming, David. So that's a great question.
From Shri Mosher, how common is it for RNs and RTs to place acute hemodialysis catheters? I live in New Hampshire, and I am not aware of any institution where RNs or RTs do this.
Also a great question. We actually have a lot of teams around the United States that have advanced their scope of practice to include CVCs. And these are normally vascular access specialists and old PICC teams, and we've transitioned even their name to make sure it encompasses what they do. So almost every state has the ability to place central venous catheters, and when they write their policy and procedure, they don't omit acute hemodialysis catheters because it is a central venous catheter. It's placed the same way. It has the same precautions. The catheter is larger. So there are several hospitals and nurse-led teams placing hemodialysis catheters today. And again, that 1% of insertion and 99% care and maintenance, you know, a lot of those teams also follow those catheters to make sure that they're performing, that the dressings are done, and that they are not, don't have an increased risk of infection opportunity. Lots of education is done. But I must remind you, it has to be in your policy and procedure and in your scope to be able to place a hemodialysis catheter. So don't cut yourself short when you're modifying your policies to include your discipline to placing CVCs. An acute hemodialysis catheter is a CVC.
Thank you. And this will be our last question. I would like to ask one that several people asked, so if we could fit this one in. Amy, it's a maintenance infection risk question. Why do the KDOQI and CDC guidelines still recommend antimicrobial ointments for dialysis catheters? These ointments have shown an increased risk of fungal infections. So this was asked a variety of, in different verbiage by many different people. So can you address this as well, Amy?
Yeah, so I think that was very interesting too. You know, as I look through the guidelines and the standards, I want people to standardize the way they do things. And I think by applying an ointment to one catheter and not the other, it's confusing to the bedside clinician. But it also, as the question was asked, the different bacteremias that potentiate or that aren't protected against with an iodine-based ointment. So what I see is that we don't have enough evidence with acute hemodialysis catheters for use of betadine, that we've stopped using it as a skin prep, we've stopped using it as a standard of care, but we continue to use it as a sealant, and that's how I think of it. I think of it as a sealant around the exit site. So I think that we can do better, and I think that we as clinicians need to study what we're using and what we're doing so that we can have enough evidence to support them moving away from that. I do think the evidence that they do have to support it is old, and we need continuous evidence, and what we have so far is evidence related to CVCs and PICCs. And again, from my standpoint, I would say that is the same type of catheter and should have the same benefit and recoil. So most hospitals in today's world have moved away from the betadine at the exit site for hemodialysis catheters, and they're only using chlorhexidine type dressings. So I think we just need more supportive evidence to move that old practice forward.
Thank you so much, Amy. You've given us great information. I hope that we all learned something. And Emily, I'll turn this back over to you.
Rita and Amy, thank you so much for a great webinar. The material that you've covered today is so important to reducing the risk for the hemodialysis vascular access. And last but not least, I'd like to thank each and every one of you, our guests in the audience today, and as well those who are listening to this recorded session. We appreciate your time and your very thoughtful attention. So thank you, everyone. Take care, and we'll see you again next time. Bye for now.